Good morning, everyone. Well, this is entering into the back end of the year 2021, which is a good year, another good year to leave behind, and looking forward to a better year next year. Before I begin, I'd like to pay my respect to the traditional owners of the land we're on, and also pay my respect to Aboriginal elders, past, present, and emerging. As you know, this session's being recorded. It will be available later on VAADA's YouTube page. And we also have the ability to put questions through on our Q&A function, which sits at the bottom of your screen. It's a pretty jam-packed agenda today. We're very lucky to have some excellent speakers and panelists talking in the general AOD mental health space, which is the theme for today's seminar. To kick things off, we've got Jason Rostant, who undertook some very complex and very efficient work for us in a consultation of our sector in September. And he'll be presenting some of the findings from that. Jason has a range of interests across alcohol and drugs and consumer-led practice, capacity building, and rights-based practice and advocacy. He's been employed previously by VAADA many years ago, worked for a minor party senator, worked at the Victorian Equal Opportunity and Human Rights Commission, and also at CoHealth as a Director of Advocacy and Partnership. And it's a great pleasure to have Jason on board. He's a great ally and supporter of the sector. Jason, over to you.
Thank you, Sam, for that welcome and that introduction. I'm really super delighted to be here for this morning's session. I'll just share my screen. Hopefully folks can see that. I would also like to start by acknowledging the traditional owners of the land that we're meeting on this morning and pay respect to elders past, present and emerging. I'm in the west of Melbourne, so zooming in from the lands of the Wurundjeri and the Bunurong people of the Kulin Nations, acknowledging that sovereignty on these lands was never ceded, and acknowledging the traditional owners of the lands from which everybody is zooming in from this morning, which presumably is right across Victoria and potentially elsewhere. Thank you for the opportunity to talk this morning. I've got about 20 to 25 minutes or so to talk through some of the key dimensions of work that's recently been undertaken on behalf of VAADA and with the AOD sector and others more broadly. Really, the purpose of this presentation this morning is about providing some scene setting for some of the discussions that will come later in today's session, who Sam will introduce later, but including Katherine Whetton from the Department of Health, and Nicole Lee and Andrew Brune, who will be talking about dimensions of AOD and mental health collaboration. So really this presentation is intended to provide a little bit of scene setting for those discussions that will follow later today. In order to do that, I'll be running through a bit of information in the next 25 or so minutes. Welcome folks to flag questions through the chat function. Julia, I think, will be picking those up, and if we've got an opportunity at the end, really happy to discuss those. As Sam indicated at the outset, the work that's been undertaken for this particular piece of work was quite complex, and the material that it generated quite extensive. So I guess the information today, a bit of a qualifier, that it is really only providing a super high level overview to the detail that was received. If folks are interested in more information, there is a summary report from the consultations that were undertaken that I believe is available through VAADA. So what I'll talk through this morning is a little bit about the VAADA project and what the organisation has been funded to deliver. I'll talk a little bit about the project context and the work that's been undertaken to date, including the consultations that Sam referred to earlier, and provide particularly a summary overview of some of the key dimensions of what was heard through that discussion. I'll then conclude really by providing a little bit of information about some of the proposed next steps in this particular piece of work, particularly as we round out, as Sam introduced, the joys of 2021 and prepare for 2022 next year. And in part of laying out those next steps, I'll also pose some of the kind of key questions that continue to be grappled with as part of this work, some of which Katherine may touch on in her presentation, and Nicole and Andrew certainly will. So a little bit about the VAADA project. So this information in this presentation, I gather that the audience today is probably a mix of people, some of whom will be very familiar with this material and some of whom for whom it will be new material. So for those who have heard it before or participated in the consultation process itself, thank you for your patience as we step through this material. So the Royal Commission into Mental Health Services in Victoria, part of a 2-year funded project that VAADA has been funded to deliver, to assist with the implementation and rollout of some of the key dimensions of the Royal Commission's findings. In particular, VAADA has been funded for the next couple of years to facilitate sector input, initially at least into the development of an integrated AOD and mental health and wellbeing framework. And so that'll be the main focus of the discussion this morning. The VAADA project includes facilitating that sector consultation specifically in relation to the framework, but also on a broader range of AOD policy issues as various elements of the Royal Commission are rolled out over the next several years. VAADA also has a role to support and engage with members of the AOD Expert Advisory Group, of which it is a member. And also to support engagement cross-sectorally, so particularly with mental health, with other parts of health and the lived and living experience peak bodies, to identify some of the current and common issues and opportunities when we're looking at this question of integrated AOD, mental health and wellbeing treatment, care and support. And I'll talk a little bit more about some of that cross-sectoral engagement a bit later in the presentation. Importantly, it's also about facilitating a dialogue across the AOD sector, so ensuring these feedback loops and opportunities for sector to plug into the vast range of other activities that are occurring across Victoria at the moment, of which many of you are directly involved, if not at least well aware. The other key dimension, I guess, to this project that's important to point out is that SHARC, as the lived and living experience peak for the AOD sector, has also been funded over this 2-year period to support many of the elements of the work that VAADA is also undertaking, but specifically from the consumer perspective. So you'd all be aware that the Royal Commission made a number of recommendations specifically in relation to this question of integration between AOD and mental health treatment, care and support for people with co-occurring needs. And in particular, recommendation 35 of the Royal Commission outlined that by the end of next year, all mental health and wellbeing services will be providing integrated treatment, care and support to people with co-occurring needs. And so for the purpose of the consultations that were undertaken in August and September, recommendation 35 was really the primary focus. This is, of course, a fast-moving environment, and there have been multiple announcements that have been made in very recent times in relation to the rollout of these particular pieces of work. So the consultation process that I'll talk about in a second commenced in late August and was required to wrap up really by the middle of September, a super tight turnaround. And even before that process was concluded, there were a number of additional significant announcements that were made. So many or all of you would be very well aware, the Royal Commission recommended between 50 and 60 adult mental health and wellbeing services would be established by the end of 2026. Last year's budget, or this year's budget, made provision for the first 20 of those, and in late August an announcement was made to establish the first 6 of these adult local mental health and wellbeing services before or by the middle of next year, largely. So Benalla, Brimbank, Frankston, Greater Geelong, Latrobe Valley and Whittlesea. But these, of course, are being fast-tracked. They're the first of a much larger number. There will be local services specifically for adults as well as for families and for young people. And there will also be higher intensity or higher acuity need redesign of the area-based mental health and wellbeing services as well. The other key development that happened while these consultations with the AOD sector were being undertaken was that a whole of community consultation process also opened up and closed towards the end of September. That process run by Capia Consulting was looking at all aspects of the delivery of local mental health and wellbeing services, whereas the work that we were undertaking at VAADA was very much more focused specifically on this question of the integration framework that I'll talk about shortly. So a much narrower focus and supported by a consultation paper that had been developed by the Department of Health, which is also available from VAADA and elsewhere quite widely by this stage. One of the important developments that occurred over the course of undertaking these consultations was that, notwithstanding the fact that those tenders for the first 6 fast-track services were opened, I think in September from memory, the process for the development of the integrated framework was extended out to May 2022. This was an important development from the point of view of the complexity of the work, the fact that the development of this proposed integrated framework is grappling with very significant and long-standing issues and challenges, both for the AOD and the mental health sector, and that it therefore requires a good degree of time to ensure that the work occurs well and occurs in a really kind of integrated way between the AOD, the mental health and the lived and living experience networks for whom these conversations are super relevant. So the work continues even though the tender processes are open and are underway. The consultation paper that the department released in August to support these conversations really looked at 4, there's 5 listed here, but 4 kind of key areas. What the department was interested to receive feedback on was a particular conceptual model for thinking about how mental illness and substance use or addiction might be responded to within an integrated system. That conceptual model isn't looking at, or wasn't looking at, service design or service models, but more at a kind of system level conceptual framework. Second thing that the consultation paper looked at was a range of draft principles and expectations. It considered the range of AOD treatment types that might be delivered within local and area-based services. And it was interested to explore how specific AOD system strengths could be retained and integrated within this newly emerging system. So the consultation process that we undertook really looked to this consultation paper as being the frame in which the conversations would be held. We undertook at very rapid succession, by which I mean between the end of August and the middle of September, a large number of consultation conversations with quite a broad cross-section of the AOD sector. And they were broken into 2 phases. The first phase was really about setting the foundation. And so in a series of first phase consultation workshops, we identified and did some work on the questions around AOD sector strengths, as well as integration enablers and barriers, and looked at the principles that were outlined in the consultation paper. The second phase of consultations, a couple of weeks later, sought to build on those foundational conversations by thinking about how the principles applied to the conceptual model, engaging the sector's response to that conceptual model, as well as considering the different treatment types. So you can see from this project rollout, really it's very closely aligned with the key areas outlined previously in the consultation paper. We also had an online survey and an open invitation for people to provide written comments if they wish to. That closed in mid-September. A super detailed report was provided to the department a week later. And then subsequent to that, there's been some more work done to develop a much more synthesized and high-level summary report, which, as I say, is now available. Notwithstanding the really short timeframes that were available for the delivery of these consultations, we had exceptional uptake from the sector. Clearly, the sector has a very strong interest in this conversation, strong motivation to be involved in the conversation, and I guess a range of issues, risks and opportunities that the sector was keen to explore in looking at the direction that integrated AOD and mental health treatment, care and support might take in Victoria over the next several years. I guess this is the most significant reform process that's impacting on the AOD sector since the last round of reforms, which, as we heard through the consultations, were less than ideal, shall we say, and so a great kind of motivation to engage in this conversation to help influence and guide and inform how this particular dimension of Royal Commission implementation is rolled out. So as you can see on this slide, we had quite a broad range of agencies represented across all 3 of the workshop phases, the briefing, phase 1 and phase 2, as well as contributions to the survey and other written responses. So what we heard through the consultations, a broad range of comments made in relation to the scope of the framework, notwithstanding the fact that the draft paper and the consultations were very focused on principles, service types and strengths of the sector and the framework itself. AOD sector reps were interested to talk about a very much broader range of considerations in thinking about the dimensions of an integrated framework for treatment, care and support. The sorts of themes that people identified was about the importance of a clear and agreed definition of integration. We know that this is hugely contested, and that's part of what Nicole and Mark and Andrew will talk about later today. People talked about the importance of having a statement of shared goals and objectives across an integrated framework, and that be universally applied across AOD and mental health services, not just in the local and area services, but more broadly within those sectors, as well as looking at the interface with other relevant key areas across people's broader biopsychosocial needs and other factors influencing determinants of health. Folks identified the importance of there being a strong outcomes framework to define the changes that the integrated framework was looking to deliver and ensure that that was underpinned by clearly articulated minimum requirements, including that they have stronger levels of accountability and oversight to ensure that the kinds of system changes that the Royal Commission was aspiring to deliver were actually implemented and delivered. And that therefore requires a range of considerations to be made around system tools, including things like minimum practice standards, protocols, structures and resources to facilitate and enable, empower and drive that change to occur. Linked to the outcomes framework, folks also identified the need for strong data collection and reporting, a strong evaluation framework, and the resources needed to undertake this work. In thinking about sector strengths, I'm not going to go into these in huge detail. They're well known to people in this room, but suffice to say that a number of the strengths that were identified through these conversations resonated and confirmed a number of those that were also reflected in the Royal Commission report, namely that there are significant skills and capabilities that reside within the AOD sector, though not always well recognised, that partly they go to the strong element within the AOD sector of peer lived and living experience workforces, peer workforces and place of consumer voice. And that AOD services are already very well versed in delivering holistic and integrated care that is inclusive, free of judgment and stigma, and has been working for a long period of time already to engage with questions of dual diagnosis and related needs. And I guess finally here that what folks pointed to was system efficiency, particularly from the point of view of return on investment, that when we look at the amount of resourcing available to the AOD sector, the bang for buck that that sector delivers is certainly very strong in terms of what it's able to achieve with limited resources. Folks talked about a number of dimensions around enablers and barriers to integration. And I guess there are a couple of dimensions that were considered in the consultation here. And this goes a little bit to the point made earlier about ensuring that when we talk about integration, we're clear about what we're talking about. Even when we're thinking about integrated treatment care and support, the consultations revealed very strongly that that integration needs to be considered and action needs to be considered at multiple levels. And those levels need to consider what's occurring both at the individual care level or care team level all the way up to the system level. Language was important here. And again, this will be part of what Nicole and Andrew talk about, that really what people were talking about was collaboration and partnership rather than integration in the sense of amalgamation, if you like, of treatment care and support models or AOD and mental health services and systems. In order to enable and support that collaborative or connected care, there are a number of dimensions that you can see on the right of the screen here that were really important considerations. That unless investment in workforce in a range of options, particularly through a lens of multi or interdisciplinary practice was made, then this integration, this collaboration that's being sought will be very difficult to achieve. It requires resourcing, it requires a clear statement of intent and accountability for actions, and it requires a whole range of activities across workforces to look at how it is that professional disciplines come together in an equitable, respectful, collaborative way that breaks down some of the silos, stereotypes, myths and expectations that exist between different workforces. The conceptual model, which you can see on the screen here, was pretty much roundly condemned, it should be said, through the consultations. People were not a fan of what it was providing. I think that's probably enough kind of said on the conceptual model, but really what folks were indicating was that it's largely a model that sectors have been operating under already. It's a bit outdated, and that particularly there are other models that might be considered that are far better. And particularly people pointed to the Minkoff and Klein CCI-SC model, as well as considering, for example, the importance of frameworks like the First Nations mental wellness framework. Consultation participants also pointed to a number of other reform processes which have had stronger integrated practice as their focus, as being important reference points for considering pathways forward. Including picking up on some of the learnings, limitations and lessons from those processes. And so examples that they pointed to, for example, were previous pieces of work in the forensic AOD integration space, looking at some of the work undertaken through MACNI, for example, the Multiple and Complex Needs Initiative, as well as some of the work undertaken through reform processes like family violence and the Orange Door, even for that matter, through the NDIS. Across the range of principles that were introduced, broadly speaking, participants didn't find great objection to the draft principles that were presented, although there were many opportunities to identify as to how they could be strengthened. But most critically on this slide, I guess, is really kind of pointing to a number of principles that were identified as missing currently. So stronger focus on human rights, holistic and wraparound care, including a strong focus on biopsychosocial models of care and harm reduction as particular foundations for the AOD sector, as well as a recognition that people with co-occurring mental health and AOD needs also require a strong focus on trauma-informed practice. There was a significant discussion in the cultural safety and wellness space, particularly from the point of view of thinking about intersectional need for people with co-occurring mental health and AOD, and the role and place of mainstream and specialist providers in appropriately responding to those needs. Unsurprisingly, participants also pointed to a much stronger focus on preventing, combating and responding to stigma and discrimination, and reflected quite extensively on the different approaches to questions of complexity and risk as they exist between the AOD and mental health systems, and also different levels within those systems. That will be picked up quite differently between local and area-based services. Rather than talking about treatment types, participants were much more interested to be talking about service types. And you can see here that there are a number of service types that were identified as missing from the original consultation paper, but that have a clear and important role in the rollout of mental health and wellbeing services. Most of them speak for themselves. I really just kind of comment on the first and the last one, perhaps, questions about the relationship between mental health and wellbeing services and current intake and assessment structures within the AOD sector were raised. And again, the importance of peer workforces and system navigation supports that must be resourced in order to support people move through what we know are super complex systems, and that people identified could risk being more complex through the delivery of the new support structures. So through all of those discussions, there were a number of areas that were identified as being future and continuing areas of focus for the further development of this work. Those that are highlighted in pink on the screen were those that the department were keen to be picked up as part of the continuing cross-sector discussions. We are well into that process now. Subsequent to the delivery of the report in September and the pulling together of a draft report, there was a cross-sector planning workshop held in October with a number of other sector peaks led by VAADA and involving Mental Health Victoria, Shark APSU, Tandem and VIMIAC. And we are now in the process, or they are in the process of developing a comprehensive plan to roll out further cross-sector consultations to be delivered really in the early part of next year as the department moves towards the delivery of the integrated framework by the beginning of May. So you can expect that there will be a number of further opportunities to engage in this discussion in coming months. Finally, there are a number of outstanding questions to be explored through this process and the myriad other conversations that are occurring. Of particular interest, and Katherine may pick up on some of these in her presentation, an interest to understand DH's strategic vision for the AOD sector and services in the context of these mental health reforms. There are significant questions around that language preference I talked about before for collaboration and coordination over integration. And Nicole and Andrew will talk about that later today. And then there are a number of questions around the approach to integration supported by effective system design to ensure that that integration occurs at all levels in that pyramid that I identified earlier, that the resources and mechanisms are in place to effectively facilitate and drive those changes, and then questions about how the principles that are finalised through the framework will translate into measurable practice and outcome requirements for which the system as a whole is accountable, particularly given the tender processes for the establishment of those first 6 services is now well underway and the framework itself is not yet in place. So significant continuing further conversations to be had and to be explored. A heap of info there, but there you go. Thank you, Sam.
Thank you so much, Jason, for a rapid fire tour of a very, very complex piece of work undertaken on behalf of us with the sector. It's fantastic, the amount of effort and work that's come out of it. You may have seen a note come into the chat around the summary report, which is available on VAADA's website for people who are interested in going through what the sector has said. And we'll be engaging with the sector and other sectors also in the coming year. So thanks, Jason. Really appreciate your efforts here. It's a very great pleasure now to be introducing Katherine Whetton, who is the Deputy Secretary of Mental Health and Wellbeing at the Victorian Department of Health. Katherine leads the Victorian Mental Health Reform Agenda, including implementations of the Royal Commission's findings across the system, and she has stewardship of mental health and alcohol and drug service sectors. Before joining the Department of Health, Katherine was the Deputy Secretary Policy, Strategy and Performance in Victorian Department of Education and Training. She has extensive experience in policy development, advocacy experience across social and economic policy areas, and works in a number of portfolios. So she's very well experienced in being able to manage the complexity of what's being undertaken in Department of Health and Mental Health at the moment. VAADA's personally very grateful for Katherine's attendance today. We hope this is the first of many opportunities to get together and talk about the issues in common. Although today's session may be a little short, we hope in future to be able to engage with Katherine again in building this relationship as we go forward and finding some common solutions to complex problems of system change and transformation. The Royal Commission does have many, many positive things to say about the Victorian AOD system, and as we go forward, we think that we're able to share these with the department and with our mental health colleagues. There's lots of insights and suggestions, and I really look forward to working together as the systems transform into the future, and so we can share our learnings. So, Katherine, please come online, and I'm handing over to you.
Sam, thanks very much, and thanks everyone for the opportunity to talk this morning. And Julia, thanks in advance for the slide clicking. So good morning, and yeah, really pleased to be part of today's conference. I'd like to acknowledge the traditional owners of the lands we're meeting on today and pay my sincere respects to elders past, present and emerging. I'd also like to acknowledge any Aboriginal people who are with us today. I'd like to recognise all people with a lived experience of trauma, neurodiversity, mental ill health and substance use or addiction, and their families, carers and supporters. And this recognition extends to the clinical and non-clinical workforces who support those with lived experience. And Sam, it's always excruciating listening to your bio when in joining things, but when Sam asked me to talk today, I was really pleased to have the opportunity and thought he asked me to talk a little bit about my background, introducing the new division, and then talking about our sense of our vision for the future of the AOD system. And keen to emphasise at the start just what a formative stage we're in. And I think you can see from Jason's presentation and the feedback there that we are really in that formative stage of wanting to understand what will work, how we should work together, and how we take it forward. So I will talk about a few things this morning in the presentation, but also happy to have a conversation at the end about some of the areas that you might be keen to delve into more, and we'll take it from there. So if we can go to the next slide, please, Julia. Thank you. So just as we talk a bit about the division, just for a couple of minutes just to talk about where I've come from. So I've been in the Mental Health and Wellbeing Deputy Secretary role since late January this year, and felt very honoured to be asked to take on the role, and have been learning a lot this year. So I have worked in the Victorian Public Service for 20 years across a number of portfolios. I think I've worked across nearly all portfolios in government except energy and resources. But other than that, have been really passionate about being a public servant and thinking about the work that we can do, whether it's in the way our built environment works and the way our transport systems run and how our economic policy functions across our community. Just yeah, very passionate about all of that, and have worked in social policy for quite a number of years across education and justice and health and human services. And yes, before the Department of Health, spent 5 years in Department of Education and Training working on our education reform agenda. And so I think, yeah, feel very passionate about what that Victorians can live good lives that they value, and that just that transformative role that accessible, equitable services that see people as whole people who live in communities, who live in families, and what that can do in people's lives. And so I have been very eager to learn the detail about the mental health system and AOD services in the sector. As I said, I have been learning a lot this year, and also very lucky to have a very skilled and dedicated team in the department as well. And so you can see here, we have changed a lot as a Department of Health over the past 12 months. So partly as a result of COVID, but also with changes with the machinery of government changes to become a separate Department of Health and Department of Human Services earlier this year. And previously we had a mental health and drugs branch, and then we also had AOD policy and commissioning sitting separately. And the Royal Commission recommended having a new mental health and wellbeing division that brought things together, and that it also needed to exist the existing parts of the department and also Mental Health Reform Victoria. And we did that and came together as a new division in July this year. So we're also in that really early stage of building ourselves as a division and the type of workforce and culture that we're keen to have in the division. And so you might know from conversations with various colleagues that we do have now mental health and AOD expertise in the one division, and that includes our policy area and commissioning as well. And you'll see on the right-hand side of that slide, we've listed the key executives in the division, who some of whom you will already know very well, and perhaps some that you may not, but they're your the key execs in the division. And then also just wanted to reflect just what an important part of our overall division AOD is, and that if we're going to fulfil the recommendations of the Royal Commission and the vision of the Royal Commission, which is what we are very, very keen to do, it will need our attention. That having AOD purely as a separate specialist system is not, that having that, maintaining that specialist system, it has to be brought in together with mental health and wellbeing as well. So while we've kept our specialist AOD policy and commissioning functions in the division, we're also increasing, our scopes of work across the division to really sharpen our focus on specialist AOD systems. So for example, we've got some new engagement branches. We've got more focus on data and evidence in the division. And then we've also got an entire new branch now that's focused on providing essential lived and living experience expertise into both our AOD and mental health policy and programs. And so that's it really does try to reflect the vision of the Royal Commission, particularly around the use of data and evidence, the putting lived experience at the centre of the reforms that we undertake as really, really critical, so that we do have linked and interoperable systems. So if we go to the next slide, talk a bit more now towards the future. And so really loved the front cover of Shark's Flip Side, the Future Edition, and thought that, you know, if you look at the many tiles that make up that picture, it really is a great reminder that, you know, we've got all of the parts that we all work on, and think about the sum of those parts can be greater when we do the work really well. And so thinking about the future of two service systems, so thinking about mental health and with AOD, we've been trying to remind ourselves very clearly in the division about thinking about the diversity of consumer needs and preferences. And so for AOD, this diversity should inform the way our services are structured. And so thinking about prevention, early intervention, treatment and harm reduction, but also then how the system supporting them is configured as well. And so that's why in the division and thinking about change, we have sought to create some stronger links between consumers and the sector so that we can plan for that diversity of experience and need in our system design and service responses. And so I just want to flag some of the new groups that we've helped set up to help us with that. So I mentioned the new lived experience branch, and that in the division, and that has 2 dedicated AOD positions to guide our internal decision making, and then sits in that broader team. We've just recently appointed Mary O'Hagan as the Executive Director of that branch, which is very, very exciting. And I know Mary also sees how important it is to think about that interoperability and linked systems, and thinking about integration of AOD. We've also then got a new lived and living experience expert advisory group, so to bring lived and living experience in from the very beginning, and then thinking about that all the way through our policy making and decision making. And that's the group that's chaired by Heather Pickard of Shark, and also Melissa Arduca from the Department of Health. We've also got a new expert advisory group that tries to bring the diversity of senior sector voices to work with us through our changes. Got a new lived experience workforce advisory group, so bringing together lived and living experience workforces across mental health, AOD, to identify and address shared priorities for our workforces. And then of course working with VAADA, who is then talking with you about the way we build change. So really keen to see that it's ambitious, but also that it's sensible and practical, and that we can actually work together to deliver that. If we go to the next slide. Thank you, Julia. So the other things that are really top of mind is trying to make sure that we are capturing the opportunities that were presented by the Royal Commission. And so capturing the opportunities, but also building on the strengths that we know exist in the AOD system already. And so certainly have learned and understand that the sector has been described as being reform fatigued, but also just how attuned the sector is into opportunities for meaningful change. And so things like, we think about responding to conditions of scarcity and surplus and severe escalations in harm. For example, thinking about the late 1990s heroin glut, the AOD system has certainly weathered some significant storms over many years, and is now delivering more care to more people. And so as with the mental health system, we do have a long way to go. And if we think about how do we ensure that we provide coordinated or continuous care, and that is by default, that care is holistic, we need to make sure we're maintaining our focus on people's outcomes and thinking of them as full and whole people. We need to be thinking about sustained infrastructure and service planning that really does reflect the cost and the value of the services we provide, and also really needing to focus on having a strong, collaborative and well-trained workforce. And so I think it is a really great discussion to be having about how the opportunities for AOD that are afforded by the Royal Commission can really be capitalised. And so some of the opportunities that got up on the slide there are the things that are on our minds in the division, but also very keen to keep hearing from you about the changes that you'd like to see and how you see those opportunities as well. Go to the next slide. Thank you. Now, Jason showed these recommendations earlier, so I won't spend a long time on them, just to recap, and I'm sure you are all familiar with them, but these are the three recommendations or components of recommendations as part of the Royal Commission that really relate in particular to supports for people with co-occurring mental illness and addiction issues. So we've got the emergency department recommendation, we've got the having the integrated care, treatment and support as that recommendation 35, and then a new statewide specialist service, and also the number of addiction specialists in Victoria as recommendation 36. And if we go to, I think it's the final slide now. Thank you. So to touch on integration, and really interesting, the language of integration, and then thinking about collaboration, and I'm really, really keen to keep having that conversation. As you'll all know, one of the first ways that we would like to open up the collaborative mental health service planning with the AOD sector is through this testing of an integrated care framework. And Jason, really appreciated your work and your presentation earlier to summarise that feedback received today. So I'm really glad that I was able to be part of that session and hear that feedback. Some very challenging timeframes that you were working towards, and part of this is that the ambition of the Royal Commission has a lot of very challenging timeframes associated with it. But thank you to VAADA and to all of you for the work and the feedback. Really, really appreciate it. I've found the feedback to be comprehensive and really constructive, and have been very pleased to see the sector appetite for person-centred and holistic care, and that thinking about intensity-sensitive conceptual models, the shared vision and goals, and then clear operating definitions to support the clear service expectations as well. So we'll be looking really closely at that feedback that we've received and coming back to you early in 2022 so that we can really look at what the best model to inform integration across all of our mental health and wellbeing services. And the high-level timeline for the rollout of integrated care is on that slide there. So a couple of observations about that, and with the challenging timeframes, we've had a really busy year this year as we've been in that early setup phase of the very large reform agenda. And then you can see that 2022 is also going to be a really busy year, because there are a number of recommendations in mental health, but also related to AOD, about having things really up and running through next year. And but the important thing to say too is that it is a 10-year reform agenda coming out of the Royal Commission, and there's certainly lots and lots of work for us to undertake. And talking with a number of people across different parts of our mental health and AOD sectors, one concern about making sure that this change is sustainable and that things are invested in, and that then we're not moving so quickly that we lose the vision of the Royal Commission as well. So as well as implementing the AOD components of the mental health reforms next year, we also are very keen to keep talking with you about how we support the standalone AOD system as well, and thinking about the unique practices and philosophies and models of care. And also talking with you about the distinct AOD demand and resourcing issues as well, and how we do manage that going forward. I will just say again in closing just what that formative stage that we're in, and so very keen to keep hearing your feedback and views as part of that work. As we have this year, but definitely going into next year too, our AOD policy and commissioning teams will be here to work with you and we'll also be supported by VAADA in consulting with you regularly, and then using those different advisory groups that we talked about earlier, including the AOD Lived and Living Experience Advisory Group and the Expert Advisory Group. I hope to be able to meet with you again, and certainly would be lovely to meet in person. That's one thing I've found challenging about the past couple of years, is not having that opportunity to meet people in person. So I look forward to being able to do that next year. And although it seems challenging to say this because it's not quite December, but I do hope that everyone can have a good December and then spend a bit of time at the end of the year having some downtime and spending some time with loved ones and having a break over summer. It's been a very big year. So with that, I'll stop there and happy to have any feedback, observations, questions. Thanks.
Thank you, Katherine. Much appreciated. I think that there is a question which may have ended up in our chat rather than the Q&A. Can you see that, Katherine?
I can. Yeah. So, so the question, I'm not sure if everyone can see it, but that idea that local mental health and wellbeing services, so the first 6 of those services are being commissioned at the moment, and that they do talk about providing integrated AOD supports with mental health. And so I definitely hearing that language about collaboration and coordination, certainly not amalgamation. But in terms of those first 6 local services, so we were very keen to get them up and running and really keen to start looking at what does it mean to have that integrated care. I don't think that's then suggesting that there's any amalgamation of services. I think this is our first go, and this is where we really, really need the feedback about what that looks like. It's our first go at trying to provide at that complex but lower acuity end for people who do have those co-occurring issues. So it is, and we're really keen to then evaluate what that looks like before we embark on looking at the future. As I think Jason was saying earlier, we've got the Royal Commission's recommended 50 to 60 of these local services. It's a new service offering in Victoria. We're really excited about it. But it's certainly not about then saying that the direction is then amalgamation into the future, but really trying to capture that idea of bringing together for those consumers who need the support of for AOD and for mental health.
Thanks, Katherine. No, I think one of the things that that piques, it raises in my mind is, what does the AOD community-based sector of the future, the standalone AOD sector, look like into the future? While there's a lot of emphasis on the wellbeing stuff, what does that look like? Are you able to allude to that? Well,
I think that's probably the big conversation that we're in the middle of having, but I do think that we see a really strong role for that AOD sector into the future. So I'm trying to say that there's a big set of recommendations around mental health reform. We do also have a specialist standalone AOD sector as well. And it's really about thinking about where are the appropriate bits to bring together for service integration, because it's how people experience care. But certainly see that, and I think that's where we'll get to as part of the integrated framework and thinking about more of our work there, the role of a separate sector as well as the role of where you have that service integration. I definitely don't have the any kind of final view on it, because I'm really keen for us to keep working on it together.
Right, yeah, that'll keep us going a while, but everyone's got a view. Claire Davies has just put another question in the chat.
Thanks, Claire. So yes, I will check with my team how we are doing, making sure that we do feedback that work at the moment. So certainly VAADA and SHARC are playing an important role in that as well. But just thinking about, I've started trying to send out more updates about the work that's happening across mental health and AOD, and we'll make sure I can talk with the team about how we do that, so that everyone's up to date with where the thinking is up to. So definitely take that on board if that's okay.
Thank you. And there's a question in the Q&A. Can you see that, Katherine?
I can't see that one, I'm afraid. So do you mind just...
All right, I'll read that. What will that mean for the consumer who has a co-occurring mental health and AOD concerns? We have learnt from lived experience advisors over the years that they would prefer a one-stop shop approach. And what the original question was.
So I'm imagining that, I think because of this very big conversation we're having about having standalone services as well as service integration, I think, and this is where we're really trying to enhance our efforts at understanding what lived and living experience wants and needs from care, and that we do get that feedback, that service integration, so that for people with co-occurring mental illness and AOD challenges, that having that integrated service is an important one. But I think from all the conversations I've been in so far, and that there is that desire and view that having some separate work as well is considered really important. But I think, I mean, lots of these questions I think go to the continued work that we're doing.
Yep, all in the fullness of time. I think there's a question there from Scott about resource cost to service undertaking the project of integration. Have you considered the impost on services and supporting agencies in this project, including workforce considerations? Workforce is a critical issue, if for no other reason than there's a fear that as the wellness centres get established, that workforce actually gets, well, other sectors may get cannibalised in that process.
Yeah, that's a really big challenge, and it's one that we're really focused on. So one of the things that the Royal Commission recommended by the end of this year is a mental health and wellbeing workforce strategy, and we have been undertaking work on that, but we're really acutely aware of the impact that may have on the AOD sector, but also when we think about other parts of our service system, that for so many of our social related services, we're drawing on the same people and very similar workforces. So it's something that actually government is more generally is having a think about, how do we try and think about the broader social services workforce. So other than it's on our minds, it is something that we're undertaking work on, and the same teams are working closely together in the division on this too, so it's absolutely recognised. But I do suspect that we do have some challenges with workforce supply, and I think that is going to be a feature of our efforts and challenge, frankly, as we move through the next few years.
If I could just put in a plug, I think the investment that was put into the workforce uplift in the AOD sector, in the additional staff and the establishment of the Elevate project, which seeks to put in place a training to fast track people into the sector, is an excellent model to be pursued into the future. And I think the uplift of investment in additional labour over many years will help stabilise our workforce, as well as contribute some flow over into other areas which are also crying out for AOD skilled up individuals. So, you know, if you want to have a talk about that one down the track, happy to pursue it.
Yeah, great. Thanks, Sam. All
right. I think we've come close to the end, and look, I really appreciate it. I hope it hasn't been too much of a heart starter for you in the first time you've probably met us. I've seen you on many occasions. I look forward to the opportunities seeing you in 3D, as we do all of us do. So many thanks for your participation, Katherine. We'll see you and at a future event.
Thanks so much, Sam. Thanks for inviting me, and I hope the rest of today goes well. And then, yeah, absolutely look forward to talking more in the future. Thanks, everyone. Take care.
No worries. Thank you very much. All right, everybody. Now we've got a short break of 10 minutes before we come back with a short presentation from Nicole Lee and a get together with some panelists to have a look at this issue of integration, collaboration, etc. Welcome all. I'm assuming everyone's back, so we'll just start the process again. And it's my very great pleasure to be introducing Dr. Nicole Lee. Nicole's been around for many years working in the sector, I think over 30 years. She's involved in many very interesting projects, activities. She advocates nationally and locally. She's given great weight and depth to many issues across the AAD sector over these years, and is very, very much a strong supporter of the alcohol and drug system, but very knowledgeable in the mental health space as well. I'm going to hand it over to Nicole, who's going to talk a little bit about some work that she's been doing with a group of individuals, and then there'll be a panel discussion. Nicole, over to you.
Thanks, Sam. That's one of the loveliest introductions I've ever had. Thanks very much for that. Let me just share my screen. Okay. I'll just add my...
Cole,
yes.
can you swap to sharing your other screen? I can see your presenter side.
Oh, that's no good. Hang on.
There we go. Oh, swap for a second.
Is that better?
Perfect.
Okay. Even though I practiced that, it still didn't work. Right, so just to add my acknowledgement of the traditional owners of Australia, and I'm speaking to you from Boonwurrung land. So I think that it really goes without saying that the co-occurrence of alcohol and other drug and mental health issues is an important thing to address. It's not really in question. And we have known about this issue for a long time. I've been working in the sector for 30 years, and really since I started working in the sector, it's been a thing that we've been grappling with. My first encounter was in 1992. I was in Townsville and I was working at the brand new acute psychiatric unit, and I was a brand new psychologist at the time. It was my very first clinical job. And at the time, in mental health, alcohol and drug issues were just thought of as a kind of nuisance to applying mental health treatments rather than part of the mix of symptoms that people might present with. But I had an interest in alcohol and drugs at the time. I had started my PhD in the area, and so I ended up seeing quite a lot of these clients. And one of my very first clients was someone with borderline personality disorder. She'd been sexually assaulted just previously, so she had quite severe PTSD as well, and she was self-harming and she was drinking an awful lot. And one day she left the hospital without telling anyone. She was on an order, so she wasn't allowed to do that. And towards the end of the day, a nurse came back to me and said, your client's back and she's very, very drunk and you need to go see her. And by the way, she's ridden into the unit on a stolen horse. So that's complexity. And it's kind of an understatement when we say that conditions are complex. It's not just about clinical symptoms of alcohol and drugs or mental health disorders. There's a whole load of other behavioural health, social issues and problems that are also in the mix that come along with it. So 30 years ago, we're still trying to solve this puzzle. And in that time that I've been working in both sectors, I have seen many attempts to address this problem, including integrating the two sectors. And that's happened a number of times in a number of jurisdictions without much success. And eventually they kind of get separated out again. The challenges of comorbidity are well studied and the problems are well understood. And there are certainly some pockets of work that are really excellent, but we've never really been able to reach a sustainable resolution at a systematic level. And the Mental Health Royal Commission, I think, has given us a catalyst for thinking about some real and effective solutions for the alcohol and drug sector. So this session this morning, in that context, I want to dive a little bit deeper to work out why we've never been able to kind of figure out this integration thing and what we might do differently instead, since I'm going to tell you it doesn't actually work that well. I'm going to talk for a little bit and outline some of the key issues, and then we have a panel of a group of movers and shakers in the alcohol and drug sector in Victoria. They've been doing some very deep thinking about this issue. They've written a paper, which I've assisted with, which will be released fairly soon. And it's called Putting People First, and I've kind of stolen that title for my little soliloquy here. So some of what we will be talking about this morning is some of the thinking that has gone into this response to the Royal Commission. So the Royal Commission was, as it suggests, a Royal Commission into the mental health sector. It was in fact relatively silent on the alcohol and drug sector, except in the context of people accessing mental health care. And we're still kind of talking about this and mixing the two things up, and I want to kind of pull them apart a little bit. What it actually recommended was that all mental health and wellbeing services provided integrated treatment, care and support to people living with mental illness and substance use or addiction, and do not exclude these consumers. It's talking to the mental health sector here. It didn't recommend integrating the two sectors to achieve this. In fact, it didn't specify a preferred approach at all. It made its recommendations with the assumption, clearly with the assumption, that the alcohol and drug sector remained as a standalone independent specialist sector, which I hope gives us a bit of an opportunity to have some input into what a different future might look like for alcohol and drugs, not just in the context of mental health. But the lack of preferred approach also poses a bit of a dilemma, because, as Jason pointed out, the term integration means different things to different people. So without some guidance, we could end up somewhere where we don't want to be. So in its kind of simplest conceptualization, there's three main types of integration. Systems integration, which is what Katherine was talking about. It's a merger of policy, funding, budget, or administration. So that's kind of at the departmental level. Service integration, which merges two types of services. So that's like pushing alcohol and drugs and mental health into one service. And treatment integration, which is the treatment of multiple problems with a single practitioner or as part of a single treatment. And as you might have heard me say before, when mental health says integration, they tend to mean subsume. So service integration in that previous graphic is what they tend to be talking about when mental health refers to integration. And this is pretty well demonstrated by this tweet from Pat McGorry. I'm sure you all know him very well. He's a very high profile mental health advocate, professor, started Origin, and he was Australian of the Year in 2010, and a very passionate supporter of mental health services. But to be frank, like many people in mental health, he actually knows very little about the alcohol and drug service system. He might know quite a bit about alcohol and drug treatment, but the service system is a different kettle of fish. When alcohol and drugs talk about integration, they tend to be thinking more about treatment integration, not service integration. But I'm going to suggest to you actually that none of these are the best way forward, and we need to be a little bit more disruptive in our thinking in terms of providing treatment for people with co-occurring problems. So one of the arguments is that alcohol and drugs is a mental health issue, so should be easy to integrate the two. It's a subset of mental health. But problem number one is this is not actually true. Alcohol and drugs is not just a mental health issue. Alcohol and drug use is not even always a problem, as we know. Even when people have mental health issues and they're using drugs, that's not necessarily a problem. And even when people experience problems with their use, those problems don't always fall into the definition of mental ill health. So, for example, I've seen plenty of people in treatment whose pattern of behaviour is causing family problems, but they're not necessarily dependent on drugs. And I have seen people who don't drink or use drugs very often, but when they do, they can't seem to stop, and they get themselves into all sorts of problems. And I've seen people who drink within recommended limits, but because they have underlying health issues, they need to reduce their drinking. And I've also seen people who use illicit drugs in risky ways, and they want to reduce harms, but they don't necessarily want to reduce their use. So none of these people would fall into the category of mental health problem. They probably wouldn't even seek mental health, they probably wouldn't seek alcohol and drug treatment if they had to go to what was labelled as a mental health service. Excuse me. So problem number 2 is that alcohol and drugs and mental health are very different service systems. It's like trying to put this square peg into a round hole. The first thing is the different focus, and we're talking about publicly funded systems here. Mental health is focused on management of acute crises and supporting long-term problems related to mental health. Mild and moderate mental health issues are actually typically seen in the primary care system or in the private sector. So people with anxiety, depression, for example, are generally not seen in public mental health services. The alcohol and drug specialist sector covers a very broad range of problems, from prevention to harm reduction to tertiary interventions, and even into supply reduction. In mental health, prevention and harm reduction activities tend to be the responsibility of health promotion organisations like Beyond Blue rather than the mental health sector. There's also very different clients and conditions in both sectors. So even though rates of comorbidity are high in both sectors, the types of comorbidity and the clients are quite different from each other. And there's actually very little overlap in the client group. We don't share a lot of clients. For mental health services, the vast majority of clients are diagnosed with low prevalence disorders. So schizophrenia, bipolar disorder, acute suicidal ideation, for example. So they're a group of people with low prevalence mental health disorders and a very wide range of drug use, from non-problematic to severe dependence. In the alcohol and drug sector, or the treatment sector, the rate of schizophrenia is definitely higher than the general population, but it's still relatively low. And the main mental health problems that we see are the high prevalence disorders like anxiety and depression. So typically they're mild to moderate high prevalence mental health issues and more severe alcohol and drug issues. Again, they're high prevalence disorders that are generally managed in primary care or the private sector. So for alcohol and drugs, if we were going to integrate with another sector, it would make more sense to be primary care, not mental health. The workforces are also very different. So mental health have a more professionalised workforce. For example, a clear distinction between different types of professional services with peer support. And alcohol and drugs have many generic psychosocial positions, which are filled by psychologists, a counsellor, a social worker, a nurse, people with lots of different backgrounds. So just as an example, the difference between the people who work in the two sectors looks a little bit like this. So there's about 3,500 psychiatrists in Australia working in mental health services, 23,000 nurses and 27,000 psychologists, roughly. In the alcohol and drug sector, there's about 150 addiction medicine specialists, so significantly less, of whom many of whom work in the private sector or in non-clinical roles. So obviously mental health are about 10 times the size of alcohol and drugs, at least in funding, but even taking that into consideration, the proportion of specialist medical professionals is very low in the alcohol and drug sector, and there is a good reason for that. It's a lot harder to work out what the rest of the workforce looks like in alcohol and drugs, but close to half of the workforce are in generic roles, so alcohol and drug worker, youth worker, support worker, but they're essentially doing clinical work and providing therapeutic interventions. 75% of alcohol and drug services across Australia are in the NGO sector, and a paper just out from DPMP at University of New South Wales showed that that was increasing. And that's compared to about 30% of the mental health sector. And I'm not suggesting that the makeup of our workforce is the problem in itself, but the point is that the two workforces are so different. When we try and mush them together, you can see who's going to be disadvantaged, and it's going to be the alcohol and drug sector. And the last piece is the model of care, which in the two sectors is very different. So mental health operate largely from a clinical, medical illness-driven model, medical first, psychosocial adjunct. And the Mental Health Royal Commission recommendations are to make a dramatic change to the way mental health operate, to move to a health and wellness model. And the new hubs are called mental health and wellness hubs, not mental illness hubs as a demonstration. But changing that kind of entrenched model of care and that culture is going to take quite some time. It's not going to be, we just set up these hubs and everything's going to shift. In alcohol and drugs, most service provision is psychosocial. We're already on board with the wellness approach. We've taken this recovery approach for a very long time, and a wellness type approach. So there's both a practical and philosophical misalignment when we're talking about integration. It's really just too simplistic to think of alcohol and drugs as a subset of mental health. There are definitely overlaps in parts, but the philosophy, values, breadth and depth of the problem are all quite different from each other. So one of the key examples is from addiction medicine. So it encompasses a wide range of medical fields, which are all essential in responding to people who have alcohol and other drug problems. General practitioners, for example, gastroenterologists, emergency department, all of these medical professionals are a part of addiction medicine. Many people with alcohol and drug issues don't require psychiatry input at all. So they don't need an addiction psychiatrist, but they may need a different type of addiction medicine specialist. So this is kind of all important because it leads to problem number 3, that when system integration happens, it tends to disadvantage the alcohol and drug sector. So what we've previously seen is a loss of funding, a loss of specialist skill, and a loss of interest in and advocacy for alcohol and drugs, not from the alcohol and drug sector, but from the combined systems integrated sector. Where policy and funding bodies look after both sectors currently, where we've already had this integration, the vast majority of resources tend to be allocated to mental health. I'm not talking about 60% or 50%, I'm talking about 90 to 95% of the resources are focused on mental health. And mental health tends to kind of swallow up alcohol and drugs because it's so much bigger. Naturally, it's kind of moves by osmosis. And I think that Katherine Whetton's presentation really highlighted this. Alcohol and drugs in the new service structure in the department has been scooped up into a mental health section. And the name of the new section in the department doesn't even include alcohol and drugs. We've already kind of been lost and subsumed into mental health. And this is pretty typical in other jurisdictions as well. And with all the will in the world to maintain the separateness of alcohol and drugs with mental health, over time, things slowly kind of shift and move by osmosis to mental health. In Tasmania, they had a state election this year, and so there was a fair bit of advocacy going on. And this is a statement from the Australian Medical Association State Election Advocacy Platform. And in Tasmania in 2014, like many other states, they centralised alcohol and drugs and mental health commissioning. And since that time, 25 positions previously in the alcohol and drug sector have moved into mental health, fully or partially. And they've taken up mental health work and dropped their alcohol and drug work. And this is from NADA CEO Rob Sterling. He said, we've seen vast improvements in alcohol and drug policy since being uncoupled from mental health. So we've tried it many times in many jurisdictions. It's not a theoretical problem. It's been tested and it fails the test every time. And I think we need to really follow the evidence, and the evidence is that integration at the systems or the service level disadvantages and creates problems for the alcohol and drug sector. So I feel like we need to, when we're thinking about this, resist any thinking that suggests that when the Royal Commission says integration, it means subsuming alcohol and drugs into mental health, either at the system or the service level. So problem number 4, and many people don't like it when I say this, but I'm going to say it anyway. We know that meeting both needs improves outcomes. That's absolutely true, but the evidence is actually not that compelling that integrating treatment is any more effective than standard care. So there is some evidence for people with low prevalence disorders. So that's, remember, the kind of disorders that they see in mental health services. And parallel and sequential treatment is actually also effective for some conditions. So integrated treatment is one option, but it's not universally indicated, and it tends to suit mental health better than it suits alcohol and drugs. The important thing is not integrating treatment. The important thing is addressing all of the problems that present themselves when someone comes to treatment. In addition to that, people who've used both mental health and alcohol and drug services have a range of other needs. So they have physical health needs, dentistry, housing, financial, legal, child protection, family violence, and we can't integrate all of these systems together. So the question is then, can we get the advantages of integration for mental health without the disadvantages of integration for alcohol and drugs? And the answer, I think, is coordinated care rather than integration. And this is a type of treatment integration, but a much more nuanced type of treatment integration. And again, this is from Tasmanian AMA. They also say that collaboration is the answer, not integration. Mental health and alcohol and drugs are practically and philosophically misaligned. So we're talking about integrating care, not integrating sectors. When we're thinking about and responding to a person's whole needs and wants, and we're working collaboratively in partnership with a range of other specialists. And we need to do this, we need to build the unique capacity and capability within each sector. And the Mental Health Royal Commission talks about building the unique capability and capacity of the mental health sector in relation to alcohol and drugs, but doesn't really talk very much about the building mental health capacity within the alcohol and drug sector. So from an alcohol and drug point of view, we need to continue to build our specialist capability as well as our mental health and our other skills. And honestly, in alcohol and drugs, we are so good at this. We've had mental health capacity building with guidelines and training and protocols, and I think we honestly do a lot better with comorbidity than currently the mental health sector do. We've had family violence capacity building, we've had trauma-informed capacity building. We're really good at integrating all these different pieces of a person's presentation into our treatment. And it really only takes a very slight shift in thinking from I treat mental health problems or I treat drug and alcohol problems to here's a person in front of me, what can I provide and what else do they need? I think the implementation of the Royal Commission recommendations is the biggest reform to the mental health sector that I've seen in my lifetime. And the Royal Commission has done amazing work distilling the very complex issues and come up with some excellent recommendations for the mental health sector. But I just remind you that when it talks about integration, it's not referring to integrating sectors or systems. And a reminder that the Royal Commission made its recommendations with the clear assumption that the alcohol and drug sector would continue to be a standalone sector. So I think we have a real opportunity here to fill the kind of silence on the alcohol and drug sector with something that is really meaningful and something that will enhance the alcohol and drug sector as well as the mental health sector when it comes to comorbidity. So I am going to stop there and move on to the next part of this session. I can see there's a few questions, but we're going to spend the next 20 minutes or so hearing from panel, and you've got an opportunity to ask questions now. So I just quickly introduce the panel. I'm just going to tell you who is on the panel because all of you will know them very, very well. Stefan Gruner is the CEO of Odyssey House in Victoria. Hi, Stefan. Andrew Brune, who's the CEO of YSAS, and Yvonne Bonomo, who's an addiction medicine specialist at St Vincent's Hospital. So I've just got a couple of questions for them to start us off, but if you want to pop your questions in the Q&A or some are going into the chat, that's fine, I can see both. And we'll try and get to as many as we can. So Stefan, you first. You run one of the biggest services in Victoria, if not Australia. What do you think the Victorian alcohol and drug sector needs from the Royal Commission to improve responses to comorbidity?
Thanks, Nicole. Just start off with a big question there. Yeah, look, I think you pointed out how the Royal Commission was focused on the mental health sector, and if the implementation is aligned with its recommendations, it's definitely going to make a big difference for those people accessing mental health care who also have some needs with AOD issues. That's clear. It's a strength of the recommendations that it suggests that we keep a specialised and separate AOD sector for all the reasons you point out to maintain that expertise. But its limitations were that it was certainly silent on all the people who will have and do have co-occurring mental health and AOD, as well as a whole range of other issues, who choose to or end up in the AOD sector. And what resourcing can go there to strengthen our system. I agree that we have had investment over years in the past to enhance the way our system supports those people around their mental health needs. But as we know, staff turnover occurs. We've got lots of new people coming into the sector. Unless we maintain and sustain the level of investment in capacity building of our workforce around mental health, that will diminish, despite our intention to treat the whole person and the variety of needs that they have. So firstly, for me, I guess the greatest opportunity that lies for us in this sector is to continue to advocate to say, in all of the implementation, we don't want a replication of the AOD sector within mental health. What we need is an enhancement of the AOD sector as well, a strengthening of it, so it can work alongside mental health and both support those people in mental health who need AOD issues, but also do well to those people coming to the AOD sector. So for me, that's the critical thing. Let's not replicate AOD within mental health. Let's strengthen AOD and work together much better than we have in the past.
Yeah, I completely agree with that. And what do you think the one big thing, or the several small things even, is for the alcohol and drug sector is going to be to get us to that point?
Well, it all comes down to what it will actually look like when someone accesses either a local or an area mental health service. The area mental health services are being tweaked or reformed to better support people around AOD, and as you say, they're going to be dealing with the acute low prevalence issues. Some of the clients there, or the people accessing the service, may need a brief intervention, may need some harm reduction advice. They may need nothing around AOD. The local services, which are meant to be much more the sort of front door to the mental health system, if they are a safe, welcoming environment for everyone who walks through the door, with people who bring credibility to both AOD and mental health, then they've got a really great opportunity through peer navigators and peer supports and people who've done training in AOD and mental health to really do great comprehensive assessments, then do some great brief interventions around reducing harm for AOD if that's needed, but they'll also understand where people may need more AOD treatment than just some simple supports. There's opportunities there for there to be support groups, whether that's family support or peer support groups and NSP in those systems. But I wouldn't expect any of the sort of more substantive AOD treatments to be delivered there unless it's AOD services co-located and working alongside in those services, because we appreciate and we understand consumers don't want to go to multiple places. They've, many of them have enjoyed the ease of access through phone calls and online during COVID. They don't want to navigate a complex system, and the simpler we can make it for them, the better. But as you said, the big thing we've got to prevent is being subsumed into mental health. And, even the workforce survey that came out from mental health, there was no indication that that was for AOD. There's no mention of AOD. Some of the intake lines for AOD mental health don't mention AOD because, 80-90% come through with mental health issues. And these are all issues. And as you say, over time, that will diminish that critical focus on AOD. And every time we get a piece of policy or a funding model or a framework or something that's come from our new branch that is being developed from within mental health, and then it says to us, here, can you put your AOD lens on this and just adapt it or adjust it for AOD? We need to go, no, we need to start from the ground and build this with AOD in mind, not just a little tweak here or there, and then make sure it works well with mental health rather than us just being a little cosmetic adjustment on the side. And those sorts of things are going to happen unless we really, and the end of the day, what this means is that the people who need AOD supports and treatment won't get what they need, because gradually over time, you'll lose the nuance and the strength of what AOD brings when you have a real focus on AOD.
Really all kind of stems from this erroneous thinking that alcohol and drugs is just an extension of mental health somehow, or some kind of subset of it, and it's not. Before I just move on to asking Yvonne a question, there's just a couple of comments that I'll just read out. So Steve says, if we fund the alcohol and drug sector better, we'll actually use the money to greater benefit the mental health sector does. But I think that funding is a big issue. We're funded at 1/10 of that of mental health, even though we see the same proportion of the population. So severely underfunded, and we can't make these changes unless we have resourcing accompanying it. And Melinda Lucas just points out that there needs to be a significant workforce upskill, as you were saying, Stefan, in mental health to ensure that harm reduction is both understood and applied in that setting. So not just training about harm reduction, but a real cultural shift in attitudes towards people who use drugs. Yvonne, let me ask you, the Royal Commission talks about addiction psychiatry a lot, that we don't have a lot of addiction medicine specialists in Australia, and most of them are not psychiatrists. The ones that we do have are not psychiatrists. Can you talk a little bit more about why this distinction is so important and what the role of addiction medicine specialists is in the alcohol and drug sector, and indeed in the mental health sector as well?
Thanks, Nicole. Look, I think we mustn't lose sight of the fact that this is a golden opportunity to change the way we work with the people that need our help. And so, yes, there's been lots of talk about addiction psychiatrists, and they are very valuable. Their input is valued. It gives us a lot of perspective. However, the Aspects Consulting report in 2013, which did a review of addiction medicine, pointed out that the complexity of addiction medicine now is such that it doesn't fit within this psychiatric framework. And that was a position that was the position of the College of Psychiatrists at the time. And that is why when addiction medicine was created as a specific medical specialty it was based at the College of Physicians, not psychiatrists, because it recognised that there's this diverse skill set that's needed in different contexts to help people with drug and alcohol problems. So we need general physicians, we need gastroenterologists, we need paediatricians with a special interest in adolescent health, we need public health physicians, we need general practitioners. All of those medical specialists have a valuable role to play in helping people with drug and alcohol problems. So we have this golden opportunity. We need to really get it right. To get it right would be one of the things to do, because I'm focusing on the medical. And of course, as you've been describing, there's much more than just the medical input. But one of the things to get it right would be to broaden the lens so that it's not just addiction psychiatry, it's addiction medicine.
Great, thanks. Thanks so much, Yvonne. Andrew, I've just got a question for you. I wanted to ask you about some of the key issues from a youth services perspective. So youth is kind of like alcohol and drugs, kind of bundled in at the last minute as a kind of special group. And we're talking about the alcohol and drug sector like it's just one thing, but there is a large adult sector, but young people and some other groups have some other specific needs. So what are some of the things that we need to think about that have a bigger impact on young people than adults when we're talking about care coordination and integration?
Thanks, Nicole. And firstly, just let me say I'm jealous of Stefan's headset and microphone. But it's a really important question. And what I'm most interested in is how we hold government to account now in implementing the Mental Health Royal Commission recommendations with the focus on wellness and holistic person-centred care. It's easy to say it, but what will it take to actually create responses that are genuinely person-centred and not illness-focused or system-centred, where people have to fit to the system? And I'm all for a no wrong door approach, but if you want to really put in place effective services for particular populations with unique needs, you have to create a right door. You have to work hard to do that. You have to then work with people to help them get through that right door. So you have to be quite proactive. And in fact, that's how come the youth AOD system formed back in the late 90s. But it's not just about young people, it's about people from LGBTQI plus backgrounds, people from backgrounds of different backgrounds of cultural and linguistic diversity, such as African Australians or people from Pacifica backgrounds, people with disabilities, etc. So I'm besides creating that right door and the kind of services that are geared towards people's particular needs and preferences, I'm really interested in making sure that we don't replicate what we've got at the moment, where there are large gaps for people. And so we need to focus on equity in the system. And it's the very people who have most complexity in their lives, who have the least resources and supports, and some of the most horrendous experiences that have had them end up where they are, that fall through the gaps in siloed systems. And that's one of the reasons why I sort of rail against words like dual diagnosis. First of all, you can take the dual out of it, because like you said, Nicole, in your presentation, it's more complex than that. And we don't want to see people as a walking diagnosis or a cluster of diagnoses. It's a person, not an it. People have dreams, aspirations, unique needs and preferences, and we just need to make sure our care is integrated around those needs. And that's why you're pointing out you can keep the integrity of different sectors and systems and then work out structures by which to integrate care in the best interests of people according to their needs and preferences. And if we can do that, we'll be really making strong advances, and like Yvonne said, taking advantage of a golden opportunity.
Great, thank you. There's a lot of kind of agreement going on, vehement agreement going on with all three of you in the chat here. and I'll just read out a couple of things. So Bella Anderson makes a really good point and says that this historic challenge could do with a thorough review before we spend money doing the same things, expecting different results. And that's the real risk here, that we're only looking from the mental health lens, and we try and upskill mental health clinicians. And we have, Bronwyn Williams points out that we have done that, tried that before for 2 decades, in fact, and we've had little traction. So it's not just a matter of kind of training or applying or resourcing. There needs to be a much more nuanced response to this that really considers both sectors as independent specialist sectors and what they need. And Gary Croton's just got a comment here that, in my opinion, the top 2 system issues are insufficient resources in both sectors, tick, and how stigmatised alcohol and drug issues are in the mental health sector, with the consequent impaired access to and quality of treatment. Macon Merlot has asked a question, and I'll just throw it open, probably the last question open to the panel. How are we going to measure success from these new implementations? Stefan, do you have any thoughts on that?
Well, this goes to some of the points Jason made about a sort of an evaluation framework and being really clear what we're actually trying to measure. But I think there's some really positive things that have come out of the department. One is the new sort of pilot that's being done, that first step in St Kilda with their consortium of people are going to pull together and document some of the ways that they've worked. But even in the new 6 first commissioned local mental health and wellbeing hubs, there's a significant amount of money over the first 2 years that's been dedicated to exploring what integrated care can look like between drug and alcohol and mental health. So that I'm not sure, the people who may be being involved in tenders may have seen that, but I'd really encourage people who are in those local areas where those first 6 will go out, get involved in that part, because I think that will document some different ways that coordination of care can actually occur and what that exactly looks like. When I talk or think even about co-location, I'm not thinking about the whole AOD sector, jumping up and being there. I'm talking about having some people from AOD sector in a sort of an in-reach capacity, or offering some groups or some of their support services within those. So it's easy for both mental health to access them informally, and for clients to, to be introduced, and for some of those referrals to work easily. So I think there's a few mechanisms built in to measure some of these outcomes, but I think, with this massive investment, it would be really great to see from the department some more formalised way of really documenting what we're trying to achieve and measuring some outcomes around that. And at the end of the day, really hearing the voices of those who access the system to see if their experiences of the system are meeting their needs. At the end of the day, that's the thing that's going to matter.
Great, thanks, Stefan. It's my life's mission now, before I retire, to have evaluation of programs built in before the program starts, rather than at the end as an afterthought. We need to wrap up now. There's still a few other kind of comments and questions coming in. But if Yvonne or Andrew, do you have any last thoughts before we wrap up?
Just to agree with Stefan's last point, that the best way to evaluate the system would be to ask the people who are using it.
Absolutely.
And I would add to that, so the consumers, but also the people working in the systems, the health professionals and the workers who are in the system. And it'll be a good system when people really want to come and work in an interconnected, strongly collaborative sector, which we can achieve. It's nuanced, as we've pointed out, it's nuanced, but it can be done. We've done it on little pilot models, as I can see in the chat, and also at our various services. It is possible. And that's when we'll know that we have success, because the consumers will say it and people will want to work in these areas and will enjoy coming to work every day.
You've inspired me, Yvonne.
Great. Thanks so much to all three of you. And I will hand back to Sam now to wrap up.
Well, this has been a great session. We got some terrific people working in our sector, and the logic being expressed here is, I think, really on the ball. And following on the comments, many in the field also agree. It's good to see people that have been working across mental health and AOD participating, and also showing general agreement in this. And like it or not, I've also been getting a range of SMS texts contributing to a level of contribution as well. Just to say that on the 6th of December, Monday the 6th, VAADA is actually organising a face-to-face get-together event, conference, if you want to call it that. It'll be at South Bank. We'll be having a few short talks and presentations, and then an opportunity for people to eyeball each other in 3D and talk to one another. You'll see the invitations just been pushed out to your chat. If you wish to register, please do so. There'll be a further feedback survey at the end of this session. If you could please let us know your thoughts, that'd be appreciated. Once again, I really thank the sector for the work they've put in this year. VAADA will make opportunities available in the coming year for further participation around this mental health space. As I said, it's been great to get some really good thinking happening so far on this, and we look forward to working with you all. And if I don't see some of you before the end of the year, I wish you all the best for Christmas and the festive season. I know it's still November, but December's coming. So thank you so much, and we'll see you at the next event.